Good evening all. I thank Dr. Praveen for giving me this opportunity. Okay, optic disc maculopathy. It's rare congenital anomaly that are a part of a spectrum of congenital cavitary optic disc anomalies that may be associated with juxtapapillary retinal detachments. So this is not so uncommon. It is seen in 1 in 10,000 of patients. So often 10 to 15% of patients, usually it is seen as bilateral, and 30 to 75% of these 10 to 15% of cases usually present with a concurrent serous detachment of the macula. Now there are various theories for this optic disc split maculopathy. So you can just tell it as there are 4 different sources for the fluid which is seen in this optic disc split maculopathy. So Linkoff and colleagues have proposed that the fluid is coming from the optic disc split. So this causes a schisis like inner layer separation of the retina. So this in fact goes for a detachment at the outer layer of the macula. So either the fluid leaks from the vessels inside the pit or it originates from the cerebrospinal region. Whereas gas has speculated that vitreous is the cause, like it causes a tangential traction at the pit which caused a passive migration of the fluid in the submacular space. Now the fourth source might be the fluid is coming from the choroid, either through the Brooks membrane or through the areas of the peripapillary atrophy. So what are the clinical features? So as you all know, it is like it's an incidental finding if the pit is alone. I remember the old post-graduation days, like whenever you see a fundus, when you see a pit, it is just like you are just getting a gift or something, and also you feel so happy that you have seen a pit. So it is kind of an incidental finding. Usually it is seen infratemporally within the nerve, 1/3 can be central. So how do you see it? It is a round or an oval depression that differs in color from the surrounding disc. So it could be either grey, it could be either yellow, or it can be even slightish black. So this is mainly, the color difference is mainly because of the amount and the location of the glial tissue inside the pit. Now usually along with the pit, the patient presents with a macular edema, or you can see a serous macular detachment, or you can see a sky of the eyes with infratemporal pits. So the patient is usually asymptomatic, but the symptoms usually starts within 3rd to 4th decade. So even though it is very rare, the reports are seen in children as well. So usually the visual acuity is normal unless associated with the serous macular detachment, and the patient usually present with the visual field defect if the defect is so large, so they can present with the paracentral arcuate scotoma. Now investigations, well yes, it is OCT imaging, so that can reveal the connection between the subretinal and the intraretinal space. Even you can see the perineural space and the vitreous cavity. So OCTA is the new multimodal imaging where you can see the decreased vascular perfusion to the area of the ODP. So as this is not associated with the brain malformations, neuroimaging is not warranted in such cases. Now fluorescein angiography we usually don't do for cases like pit and all, but if at all you do, you can see the progressive staining of the pit as the study progresses, but no leakage or hypofluorescence within the retina is seen if the pit is alone. But suppose if you see a chronic edema, you can see the typical RPE atrophy changes. Now P-scan if you see, you can see herniation of dysplastic retinal tissue which can extend to the subarachnoid space through a defect in the lamina cribrosa. Now what are the differential diagnoses? Optic nerve coloboma, choroidal and scupular crescent, tilted disc, circumpapillary staphyloma, hypoplastic disc, glaucomatous optic neuropathy where you call it as a pseudopit. Now management, observation, 25% resolves spontaneously, you need not do anything. Laser photocoagulation is obsolete as of now. It creates a barrier of chorioretinal adhesions at the temporal optic disc border, and it needed repeated treatments. But this will cause visual defects as we are lasering on the maculopapillar bundle. So laser photocoagulation is obsolete. Now gas can tamponade can be attempted with laser photocoagulation. So what it does? As already mentioned, the gas induces pneumatic displacement of the outer layer detachment and it improves the central vision. So pars plana vitrectomy with gas tamponade with or without laser photocoagulation can be done in eyes with severe visual loss. Now the surgical management, so now the current standard of current management standard is you can go for a pars plana vitrectomy with ILM peeling. Inner retinal fenestrations, that is known as the spade procedure, can be attempted. Macular buckling can be done, and After pars plana vitrectomy, you can plug the optic disc with various options, like one is an inverted ILM flap, autologous scleral flap, autologous platelet concentrator, and whatnot. You can even do with a fibrin glue. So plugging the optic disc pit, you can see the ILM flap over here. So this is one option. And I'm sorry, the video is not playing. You can see at the arrow, you can see, after a pars plana vitrectomy, you can see how the ILM has been used as a plugging. How is it plugging on the pit? Now this is plugging the optic disc pit with an autologous scleral flap. And macular buccal, I have not seen it, but that is seen in the literature. So this is the fixation with a sponge which is applied at 6 to 12 o'clock meridian, which provides a compression ab external, and it acts as a barrier preventing the flow of fluid from the optic disc pit to the macula. So you can do fibrin glue as well. So there are some other tried modalities, like wherever the pars plana vitrectomy with plugging with this fibrin glue or with ILM flap it has been failed, you can go ahead with subthreshold micropulse laser, so which target the RP without damaging the photoreceptors, as we do in chronic CSR. So there are some studies which shows that you can even give oral spironolactone along with topical dorzolamide. So you have to find out, the long-term studies is yet to come out. So these are the tried modalities in optic disc pit maculopathy. Thank you.
Thank you. Nicely presented.